and then I will share my screen. All right, so you should be able to see this particular case study. All right, there we go. And then, oops, that's too much. All right, I think we got it from here. All right, so this was the case scenario. So this was number 2. And okay. So you guys have all of this, you know the backstory. So tell me, based off of the scenario and the chart review, what things do you find concerning and or alarming? So what things from this scenario do you find concerning and or alarming?
The blood pressure.
Okay, family history of heart disease, the blood pressure, high blood pressure, diabetes, the brother that was still living or is still living, couple of deceased parents from cardiovascular disease from one form or another.
Mm-hmm.
So she was diagnosed with hypertension 2 months ago. She received a prescription for thiazide. And that's usually where they start folks out at, is giving them a diuretic, and then they move on to other blood pressure medications. All medications cannot work for all ethnic groups. So you will probably see more African Americans on calcium channel blockers like diltiazem, or the other name for that is cardizem. Or you may see them on something like Bidil, B-I-D-I-L, and that's because they can't take Vasotec and things like that. They can take it, but it doesn't really work for them as well. Black women in particular should not take any ACE inhibitors. They run the risk of developing something called angioedema. So basically their face, their throat, and all of the airway swells up. So if you know any African American women that are on, or Black women that are on ACE inhibitors, then they need to, that's not one, that would not be a good blood pressure medication for their control. So they stopped taking the diuretic 2 weeks ago. They're dizzy. They get up during the night to empty their bladder, which, you know, this is their reason for them not taking the thiazide diuretic. So at the clinic visit, they're fearful because their mother died of a stroke. And at their age, they're afraid that they will also suffer the same. So her concern is, I've never smoked and I don't drink, but I'm also afraid of the high blood pressure as well. So in her backstory further down, she's 150/92. Is that high blood pressure, yes or no?
Yes.
Yes, that is high blood pressure. Thank you. And then just kind of looking at the timeline. So January 2nd, she was 150/92. The 31st, that's 30 days later, she was still 156/94. And then they gave her the prescription for the hydrochlorothiazide, which is a thiazide diuretic. And now we are 30 days later, and she's barely at 140/90. So is that normal? Or do you think she should be in the 130s?
I think with the history of the family history, she should be on the around 130, because with 140/90 is kind of high based on her family history of high blood pressure.
I mean, 30 days, they should start seeing some kind of results. So this kind of begs the question, what's her diet like? Have she cut back on, salt or, like lunch meats and canned goods and things of that nature? So could that be her next problem? Now she did, she stopped taking it. So evidently when she stopped taking it, that was definitely not the right thing to do. So according to the most recent guidelines, the treatment for blood pressure in MP's blood pressure falls under which classification? And I believe that's a type 1, 2, 3 or stage 1, 2, 3. So stage 1 is where it's the diastolic or the systolic is from 140 to 159. So she's always been stage 1 based on even her previous history. The diastolic is 99 or 90 to 99. She's fallen under that range as well. So, and this is on on each of 2 or more office visits. So that's one thing. All right, so let's scroll down. What could MP be doing that is causing her nocturia? So she's saying that when she took the medication, she was up all night. So what would cause that?
Maybe she's taking the medication at night before she goes to bed.
She's probably, and she could be taking it in the afternoon. So taking, if you're taking a medication and this is designed to make you pee, the best time to take it would be when?
In the morning.
In the morning. So those are instructions we want to give our patients. We want to let them make sure they know that if you're going to take a diuretic, you need to take it first thing in the morning so they can pee all day and sleep all night. So we don't want them up at night emptying bladders. Okay. So here she could be taking it late in the afternoon or evening instead of in the morning. So we've kind of covered that. So today, this is her vital signs. Now remember, she stopped taking them 2 weeks ago. Did her blood pressure get better or worse?
Worse.
Got worse. Her most recent BMP, basic metabolic panel, and fasting lipids are within normal limits. She's 5'4", weighs 110 pounds, so weight's not an issue. And she tells you that she tries to go on walks, but she doesn't like to walk alone. And so she's only done so occasionally. So what risk factors does she have that increases her risk of cardiovascular disease? Family history, her own personal history, right?
And the fact that she's non-compliant with the medication.
Absolutely. The fact that she stopped taking it definitely is not good. So what well, we don't know what her diet is just yet, so we need to see what, just because you're 110 pounds doesn't necessarily mean you're healthy. So although her other stuff was within normal limits, we don't really know the true numbers as of yet. So we'll see. The food may not even play a factor, but we'll find out. There was something else I was going to say. Oh, so say for instance, instead of her not, seeing a physician within 2 weeks, say if it was 15 years, what kind of fate would she be looking at this particular time? Because we talked about this in class.
Can you repeat the question, please?
So when you leave high blood pressure untreated, we know she could potentially have a stroke. This is her concern. But what other issues could she potentially have? She could have kidney failure. She can have what else? Heart failure. She can have an aneurysm. So there's other complications that she can face by the non-compliance. All right, so high blood pressure, physical inactivity. She's 65 and over, postmenopausal, family history, and the fact that her mother had a premature death at 65 as well. All right, so she continues to be high The internist decides to put her on another drug and recommends that she try again with the ACTZ. So this seems like there was some lack of education here upon discharge initially. So according to the JNC8 national guidelines, what drug category or categories are recommended for her at this time? Okay, diuretics. Anything else? And if you weren't sure, you could have just, typed in JNC8 on Google to look at the guidelines to kind of help you, follow through. And they're probably higher now. They have 2019 guidelines. So did anybody do that? Calcium channel blockers. So when you did the case studies, where did you gather your data? Because it's actually telling you where to go. And the JNC8 basically stands for the 8th Joint National Committee. So that's what that means.
Calcium channel blocker.
What are ARBs? And I don't disagree. I'm just, when you're putting it out there, just kind of explain a little bit more. What is an ARB?
An angiotensin receptor blocker.
Angiotensin receptor blocker. So basically, remember that angiotensin 1 into angiotensin 2, it blocks the receptor. So even if the conversion, if it was going to convert from 1 to 2, the receptor's blocked, so therefore it doesn't allow the conversion, which means the sodium can't be released. And then you have some that actually will allow the conversion to happen, but then block the action once the conversion happens or occurs. So we have diuretics, we have ACE inhibitors, we have the angiotensin receptor blockers, we have beta blockers, we have calcium channel blockers, vasodilators, and centrally acting agents. So all of those would be potentials, but for her, and based on her situation, she's stage 1, then what meds would be appropriate for stage 1? Because right now she's now at the 160s, but she was 150. And I believe they go into, whether you're black, non-black, etc. So patients of African American descent that have no diabetes or CKD, the guidelines recommend calcium channel blockers, which is what I talked about before, and the thiazide type diuretic. So you may see someone on a calcium channel blocker like diltiazem and HCTZ. It'll be together. So they'll start there before they'll do any others. If they're not effective, then the guidelines recommend a dose adjustment and or an addition of an angiotensin converting enzyme. Now I can tell you, not for African Americans, they don't need to be on ACE inhibitors, especially women. So they may go like to a beta blocker or something like that, or an alpha channel blocker or something of that nature. Now, some physicians have gone ahead and given that ACE inhibitor, but that patient runs the risk of developing angioedema at that particular time. All right, so they go on to ask whether there's anything else they should be doing to help their blood pressure get better. Do I need to lose weight? Look up her weight and height for her age and her body mass.
No, she doesn't need
She's
to.
not overweight. I mean, just by the numbers, 5'4" and 110 pounds. She's probably underweight, but okay. So she's either at optimal or slightly underweight. So she doesn't need to lose weight. What non-pharmacological lifestyle alteration measures might help her control her BP?
That.
All right, diet. But we haven't even gotten to her diet, but we can limit the salt if one is salt sensitive. So we need to see if she's a salt sensitive person. So basically, if they ate some chips and then, they ate some chips and then, all of a sudden they just started swelling, then that would definitely be a concern. Let's see, what else besides diet? Exercise, okay. DASH diet. So that's also effective, usually within 2 weeks of lowering blood pressure. All right. Reduce caffeine and alcohol intake. That can help lower it, but she doesn't drink. Routine aerobics, like walking, the one thing she doesn't like to do. That would be helpful. Meditation's always good. And I think what bothers people about the whole exercise is if they haven't moved around in a while, just that motivation to get moving. You don't have to, go out there and run a marathon. You just have to start moving a little bit. And then build yourself up to, if you want to walk 5 miles, walk 5 miles. Then other interventions such as stress management might help her. So the meditation would be a definite good option for her. All right, so here we are. This is what we give her. And add a prescription of benazepril or Lotensin. So before we go any further, benazepril, what kind of medicine is that? I actually covered this in lecture just Tuesday.
So calcium channel blocker.
All the ones that end in pril, P-R-I-L, they're all ACE inhibitors. Yep, if they end in P-R-I-L, that's an ACE inhibitor. So captopril, enalapril, all ACE inhibitors. So they give her the diuretic, and then they add in Lotensin. She has to come back, get blood work. She's to monitor BP at least twice a week, and return for a medication management in a month. Yep, you don't need a whole lot. It's not, some of these doses are, when you look at the manufacturer's recommendation, some of them have low numbers. She is a Black female. Let me go back just to make sure. We are talking about a Black woman. Yep, African American, right there. We did that, and so we're here. Okay. So I will say she should not be on it, but this is usually the pathway that physicians take. So unless it's specifically written in your book or I would check my pharmacology book, then, you know, we'll have to either go with it or not. But it is a ACE inhibitor. All right, so the question of the day is, why did they decrease the dose of the hydrochlorothiazide? Because she was on 25 milligrams. Because they added the ACE inhibitor? Okay. So she's been complaining of the dizziness, which may have led to her orthostatic hypotension, or may lead there. So since she's elderly, she may be more sensitive to hypotensive effects. So they adjusted the dose just to see if this would eliminate the problem. You need to provide education about side effects. So what type of side effects would you discuss? And so they asked you to select all that apply. So what did you choose? From your case study?
Dizziness.
Okay.
Maybe headache.
Say that again.
Headache.
Headache, okay. Well, angioedema for sure. But dizziness, lightheadedness, which is lightheadedness or fainting, all of those are the same. Nausea, vomiting, diarrhea, those are some common ones. Would you be concerned about any electrolytes?
Yes.
Which one?
Potassium.
Potassium. Yep. So A, B, and E. Those are common, as well as postural hypotension with position changes. The other ones are not correct. It is sometimes difficult to remember whether one has taken one's medication. So what techniques could you tell them to do to make sure that they don't over-medicate themselves? Pill box, it will be a good one. A timer to remind them, hey, this is, you know, when I need to take my meds. An alarm. Kind of just having a routine. So you take it in the morning when you get up and take it at bedtime. So right before you go to bed, if it's supposed to be taken 2 times a day. So use a day of the week medication holder. So that's the pill box. Make a check mark on a calendar. Those are options. Place their medication bottles in an area that's convenient for her to see. So after teaching the session, which statement indicates a need for further instructions? Doesn't this sound like a test question?
Yeah.
This is like, what do you do next? Not necessarily saying this is one, but just, you know, food for thought. So how do you know that we need to provide further education?
C.
Okay. Do you all agree, C? All right. Skipping doses is not recommended. Awesome. She goes back in a month. She tells you that she feels fine and does not have any side effects. Her BP, she checked it twice a week, and it's been in the 130. So remember in the beginning of the conversation, I said, so what should her blood pressure be afterwards? It should pretty much be in the 130s. The one thing I can caution you with is we don't want their blood pressure, you know, in the 110s. We don't want it that low. We don't want it less than 120. Too low of a BP can actually cause a person to produce clots and have a stroke. So we don't want to do that. All right, so when someone is taking hydrochlorothiazide and angiotensin converting enzyme inhibitor, what laboratory results would you expect to monitor?
Potassium, because
Okay.
of the thiazide.
Yep, potassium, because it can decrease the levels and they're going to be peeing out. But the ACE inhibitors can cause potassium levels to increase. So there's a potential for these two drugs to actually cause a null balance at the end. They can cause sodium to decrease and the creatinine levels. Glucose levels can be increased with the hydrochlorothiazide, but decrease magnesium levels. So you just need to get a full panel. Okay. Here's another review. This is what NCLEX makes you do. Look at different pages of the chart. So potassium normal?
Yes.
But it's on the lower end, right?
Mm-hmm.
Sodium it's normal, but it's on the lower end. Creatinine, is that normal? What's our creatinine? Like 1.6 to 0.6 to 1.2? At least somewhere in that area. So still low, but pretty close. What about magnesium? Because we just had fluid and electrolytes, right?
Yeah, her magnesium is fine.
Okay. So although it's fine, it's closer to the lower end of normal, right? So what lab results, if any, are of concern? I didn't hear that. If somebody, the glucose, okay, that is a little elevated. BUN, what's normal? Instead of me telling you guys all the time. Educate me tonight. That's actually normal, right? Shouldn't be any more than 20. Okay. All right, so everything's good. This only thing that's slightly elevated is the glucose. And so they can have an increase in the normal range of glucose levels after the age of 50. But so does the hydrochlorothiazide can also cause that to be an issue. All right, so here's her blood pressure. She asked whether these BP readings are okay. How do you respond? Girl, you hit it out the park. Okay, it is high. It is a little high, but would probably be her new normal. Does that make sense? Because she currently has high blood pressure. So compare these readings with the national standard and the goal for which you both agreed. So there's going to be a number that their physician's going to agree that, hey, this is where we want you to hang around. So if you're in this range, then you're good. All right. So list at least 3 important ways that you can help her maintain success.
Medication compliant.
Okay, so how can we make her medication compliant? Just tell her, hey, you need to take your medicines.
Make sure that we explain to her how important it's important for her to take her medication.
Okay.
and tell her to call the clinic if she have any question, any concern regarding the medication, and call if she have any side effects. And do not
Okay.
skip any dose. Take her medication as prescribed.
So we can talk to her about the DASH diet, see if she has a support system at home. Check her blood pressure before the medication, see where it is, check it afterwards. We basically want to educate her on making sure she takes it every day. She takes it at the appropriate time to minimize her getting up in the middle of the night to pee. Look at other avenues to minimize stress. So remind her of the goal that you're trying to accomplish, or for her, tell her how proud of her she is. So basically support system and praise. And review her progress. Remind her of the necessity to stick into the treatment. So that way, she sees that you value her in following through and the need to make this right or better. And sometimes you can tell patients all the right things and they will not be compliant. So it doesn't mean you did anything wrong. All right, so she ate lunch with her garden club members, and that most of the women take different blood pressure medications than she does. She asks why their pills are different shapes and colors. How can you explain the difference? So I started this in the beginning. Okay, they may be different strengths. They could be, she's already said they're different blood pressure pills, so it's different medications. And one blood pressure medication does not work for all people. So there's many different drugs. The goal of her therapy is to find the medication that adequately controls her BP. Everyone's history is different, so she may find that her friends are on different medications. Many drugs have generic versions, so that's another avenue that you can discuss. So during the visit, you ask her, when was your last eye exam? She answers, I'm not sure, probably about 2 years ago. What does that have to do with her blood pressure? And what is your response?
Because blood pressure can cause I think it's retinopathy, can cause eye problems. So
Like what?
let me see.
Pressure in the eye? You're talking about like glaucoma? But isn't that diabetes?
No, it's not glaucoma. It has another name.
Yeah, but glaucoma is related to diabetes, right?
Yes.
Okay.
No, but complication of hypertension.
Well, if you have high blood pressure, all your vessels are affected, not just the ones in your arms and around your heart. It's every vessel in your body. So couldn't that particularly affect the vasculature of the eyes and damage, the vessels around the macula? So the vessels could, be damaged and result in blindness because it's not being perfused. The optic nerve is what we're speaking about here. So 3 months later, she's doing good on her meds. Her average BP is 130/78. She participates at the senior citizens group. She's walking at the mall. She has not done as well with decreasing her salt intake, but says she's trying. So is there anything you could probably suggest to her then? I mean, you talked about the DASH diet. Is there anything else you could potentially offer her, Mrs. Dash? That's true. That's good. That's actually some good seasoning, by the way, Mrs. Dash. Maybe fresh versus canned goods. fresh or frozen before canned goods. Fresh preferably, frozen is your secondary, and then, you know, worst case scenario, if you're in a pinch or if you're in a bind, then canned goods. You know, maybe look at seeing if somebody can cook meals for her that, you know, that doesn't contain salt, like her daughter or something like that. So, all right. So what other case study do you want to cover? What number? So any further questions on high blood pressure? Are we good there?
Yes.
So you had 4 case studies. You had a heart failure case study. You had a pregnancy, not pregnancy. Yeah, pregnancy-induced hypertension. So we can go there. I was like, you had a pregnancy. I'm like, no, you didn't, but yeah, you did.
Yes.
Okay.
129.
Okay. Let me get to that one real quick. Give me that case number very quickly, please.
129.
129. Thank you so much. All right. Let me switch out and then switch out case studies. I'm going to stop sharing. I'm going to reshare this case study. Oh, you may have already had it up there. Okay. All right. So you guys know what a gravida is, right? So where it says index words on here, it says index words, and the first word is gravida.
Yes.
That is the number of times that person has been pregnant. So it's the number of times a person has been pregnant. If this is her first time being pregnant, so I'm right here. This is where I'm at. So I'm talking about this word right here. That means number of pregnancies. If it was her first time, then it'll say prima gravida, primi, P-R-I-M-I. If she's never been pregnant, she will be a nulli gravida, N-U-L-L-I. Para means the number of birthing sessions. So that means when the mother went into labor, that's a birthing session. And it doesn't mean the number of babies she put out in the birthing session. She could have put out a litter of kids, but that's still one birthing session. So it could have been twins, triplets, quadruplets, quintuplets, sextuplets. So that's just a birthing session, like Octomom. Okay.
Okay.
All right, so let's move on. All right, so she comes into the clinic. She's missed 2 menstrual periods or 2 menstrual cycles, right?
Mhm.
And she thinks that she might be pregnant. Ruh-roh. Let's see. Ooh, no, wrong way. There we go. She thinks she might be pregnant. And she did a home pregnancy test and the test results were positive. Okay. As the intake nurse, you're responsible for gathering information. What are the 2 most important questions you want to ask to determine possible pregnancy?
When was your last menstrual period?
Okay. Are you sexually active too? Right?
Mm-hmm.
And not necessarily just the last menstrual period, but her last normal one. Because sometimes you can bleed, but it'll be short. It may not necessarily be your normal period. So when was the first day of her last menstrual period? And when was the date of her last intercourse?
And can we also ask her if her periods are usually regular or irregular?
Yeah. Because if you have irregular periods, it's kind of hard to pinpoint pregnancy or ovulation for that matter. So she may be thinking she in the clear and she could be technically in the danger zone. Does that make sense?
Yeah.
Because it's hard to determine, depending on how folks are practicing, that'd be kind of hard to determine. And it's a guesstimate. I mean, sometimes people could be 2 weeks, 3 weeks, 1 week off. So you just have to gauge it from that perspective. Okay.
Mm-hmm.
All right. Moving on. So you ask whether she's ever been pregnant. She tells you she has never been pregnant. So based on the information I gave you earlier, is she a prima gravida, multigravida, or nulli gravida?
She might a preemie.
Well, she's never been pregnant before. We don't know if she's pregnant yet, but we're going to base it like now she's not pregnant. So, or she's never been pregnant. So what would that be? A G what?
No, I don't know how to say it.
All right, so let's stop share here, and I'm going to share the whiteboard. And maybe this will help make some sense of it. All right, let's see what I can do here on this little thing. Okay, so if she is a, I can't see my little board. There we go. So she is a, oh, there, literally, girl, get real. Text. Never been pregnant. Hey, this is driving me nuts. Let's just hit clear. Now. Okay, the stupid pen won't write. Can we just draw? There we go. She's never been pregnant. So that means nully or nulla, which means none. If this is her first time, That'd be premia prima. This will be first time. If it was she's been pregnant multiple times, then this will be more than one. Okay. So right now, when you have a person that you're thinking is pregnant, any type of potential for pregnancies, they do something called the GPA. This is the gravida para, and this is abortions. There are many types of abortions besides elective. The spontaneous abortion, we have kind of destigmatized it to miscarriage. We have missed abortions, we have inevitable abortions, we have therapeutic abortions, we have complete, incomplete. So that means there's still some fetal parts remaining. So there's different types of abortions. So when you have somebody of childbearing age, you're going to have to get this GPA status. Oops, I didn't mean to do that, but you get it. So if she's never been pregnant, then this would be a G0. This would be a P0. And this would be an A0. Correct? Now, if we find out later on in this scenario that she actually is pregnant now, then this is going to change to G1. Has she had a birthing session? Yes or no?
No.
No. So she'll be a P0. And right now, we don't know of her having any abortions or that she's aborted this particular baby. So we can't say that, she's had an abortion. So this would be her gravida para status. So you have to, make sure that you carry that piece through. And then you would add in there her last normal menstrual period and you provide the date, right? Yeah. And then I would make some documentation whether if this was her true normal or was it, light or scanty, and then the number of days. So we did talk about being sexually active, use of protection, multiple partners. You got to ask those questions. Okay. So does that clear it up about the gravida para status?
Yes.
Okay. All right. So let's roll on. I'm going to clear this and then take that away, unshare, and then go back to the case study. All right. So you ask whether she's ever been pregnant, and then we go back, this is the question. So because she is a gravida 1, we're presuming now she's pregnant. But we did not, she's at the beginning, she thought she might not be. So if she's pregnant, then you would record as a G1, just like I said. And this is just the terms. So this is what we would need to complete the TPAL report. Gravida refers to pregnancy. Para refers to number of birthing sessions. Abortions would be your A. What's your L? I didn't hear that. Oops, sorry. The L is living children. Okay, living children. So Total number of pregnancies is the gravida. T stands for the term births. P stands for the preterm births. Abortions means as the A, and L is the living children. So that's what TPAL is. And here, abortions will be before 20 weeks gestation. So based on the TPAL, the gravida TPAL, that would be a G1, then para 0, abortion 0, term birth 0s, preterm 0, etc. So we need to do the intake interview. What categories will you address? What about signs and symptoms? Any lower abdominal pain, any bleeding?
Any history of STD?
Ectopic pregnancy, you mean?
Even ectopic sexual transmitted disease.
Oh, STIs, okay.
Yeah.
So STIs, yeah. Sexually transmitted infections. Use of contraceptives, is she nauseated? Current past medical history. Why do we want to know about any of these? Diabetes, heart disease, sickle cell.
The diabetes, because
You can end up with gestational diabetes.
yes.
Yeah. Sickle cell anemia, that could be passed on to the baby. So we want to know if she's a carrier, if she have any trace, she has the trait of sickle cell. Yeah, pap smears. All right, allergies, medications, including herbals, social and occupational history, like what? What kind of social history?
Is she drinking? Did she go out and drink? Any drug use?
Exactly. Drugs and alcohol. Okay. Physical abuse, because if she's been physically abused, then this means the baby's in danger too, correct?
Yeah.
All right. Vaccinations, especially rubella. What is rubella? Is that the measles? Mumps, measles, rubella. What's rubella? So it's not measles if it's in the word. But it is the measles. Which one? Your regular measles? Is it Australian measles? What's the other measles? German. There we go. All right. So rubella is actually German measles. Partner history. That's important. Are you exclusive? You've all seen the Jerry Springer show. People be on there 49 times. I think he the baby daddy. The baby looked like him 49 times. Like, baby girl. Risk factors. Age less than 20 or over 35, any pre-existing medical conditions, discomforts, concerns, questions, nutrition. All of those are going to be important pieces. So as we move forward, according to the clinic protocol, you obtain the following for her prenatal record: her CBC, her blood type with Rh factor, UA. We're going to look at protein, glucose, vital signs, height, weight. And then the nurse midwife comes in, does an examination, including a pelvic exam, and confirms we're pregnant. So she has a gynecoid pelvis by measurement, and the fetus is approximately 6 weeks gestation. Here's her chart review. Any concerns?
No.
Okay. Do any of these vitals concern you? No, they're normal. All right, so last date was February 2nd. How do you calculate her due date? Basically, what is Nagel's rule?
What's the February 2nd?
So Nagel, Negel, according to your textbook. Or it's actually Naegele. What's that formula?
Yes, period.
So according to Lippincott, do you add a year, subtract 3 months, and then add 7 days? Or do you add 7 days, subtract 3 months? Which way? So subtract 3 months first. Okay, so if you subtract, so okay, we'll start with add 7 days. So we'll add 7 days. That'll be February 9th, right? We got to take back 3 months. So January, December, November. So we're at November 9th of whatever the following year. So that's one way. Someone said they thought they read let's see, 2, 1. That you subtract 3 months first. So if you take 2 minus 3, it's kind of hard. That's the second month. So it'd be January, December, November, and then add 7 days. So let's see. Count backwards 3 months, then add 7 days. Now this is interesting, or add 7 days and count forward 9 months. So November 9th. Now where you will get tripped up is if there's like a 31st in there or leap year. This Nagel's rule will not work. You'll be off. So when you get the third semester, they'll cover Nagel's rule again. All right. So what is the significance of a gynecoid pelvis? It just basically means it's adequate for the fetus to pass through without difficulty. Sometimes a gravid mother's pelvis is too tiny for the baby, like when they're having babies at 9, 10, and 11 years of age. What specimens are important to get during this exam? Pap smear, gonorrhea, chlamydia, herpes. Those will all be good.
Blood draw for HIV, syphilis.
So I can see, I don't know about the HIV one, but the biggest one here would be the last infection that's listed, which is the group B strep. That's more common. Now the HPV, because if you have multiple partners, cervical and vaginal smears, to send for diagnosis of chlamydia, gonorrhea, and all those others. All right, so nursing interventions focus on monitoring the mother and fetus for growth and development, looking for any complications, teaching her about nutrition and how to deal with common discomforts, you know, the vitamins, right? The multivites. And what vitamin, mineral are we specifically wanting them to make sure they ingest?
Folic acid.
Why?
To prevent spinal bifida.
So neural tube diseases. So yeah, folic acid is. All right. So there's a psych assessment done. And how do attitudes, belief, and feelings affect pregnancy?
Belief and feeling affect the attitude. So the belief is it related to like culture or religion? Because
It affects the fetus.
So it also affects the mother's ability to bond with the baby. You know, did they want the pregnancy? Not. Is this going to be a change of their lifestyle? You know, if they were in school, or that's going to be different. Are they mentally capable of a whole human person? Because it's not like, you know, the Kool-Aid babies back in the day where you could just give them back to the store. So you can't turn the baby in. Well, actually you can. If people don't want them, they can bring them to the fire station and to the police department without reprisal. So cultural preferences, you know, help them take care of themselves, how they view the pregnancy, you know, how their partner assist, then that will, you know, also help the individual. And it's important for, you know, what's important to them in reference to gender. Most people don't care about gender. 10 fingers, 10 toes, they can see, they can hear, they're good. Ambivalence, mixed feelings, even if the pregnancy was planned. Acceptance of the pregnancy. Sometimes people focus on themselves and dreams about the baby. Mood swings, body image concerns. All right. All right. So these are favorite foods. Which, if any, should she avoid eating?
the sushi.
A, B, and D.
ABD, ABE, ABD. Hot dogs, sushi, and cheddar cheese. And this is why. So any raw foods should definitely be off the table. All right. What information is important to include at every visit? Pain, bleeding.
If she's having morning sickness, monitor her weight if she has been losing weight.
Well, more than 6 is an expectation. But fetal movement is definitely something you want to know. So here we go. Prenatal visits. Heart rate, fetal heart rate should be monitored. What's normal fetal heart rate?
100 to 140.
120 to 160. How much weight gain should she have? Now, I hate to tell you, the baby's stomach is so small, so when people say they're eating for two, they really eating for themselves. The baby only take a little bit of that. So the rest of it just sticks on you to the hips, booty, and thighs, HBT. If the blood pressure starts to go up, if they start having hyperreflexia with deep tendon reflexes, what's the electrolyte imbalance here?
Magnesium.
Magnesium. Look for edema to the hands, face, legs, and feet, because that's common in pregnancy-induced hypertension. And then our two concerns here would be preeclampsia and eclampsia. What's the difference?
One is with seizures,
Which one is that?
eclampsia.
And yep, and preeclampsia, they have all these signs and symptoms: edema and visual changes like blurred vision, double vision, headaches, dizziness, seeing sparkly lights. But what makes them different is that eclampsia, you have all of that, plus you start having seizures. But that's a magnesium imbalance. Urine for glucose and protein. They do that glucose tolerance test between 24 and 28 weeks to check for gestational diabetes. We talked about fetal movement, the need to take prenatal vitamins and the mineral supplements to provide folic acid and B6. Also to decrease low birth weight babies and premature delivery. We covered the food safety, and then making sure they're drinking some water. Okay, here we go. Select all that apply, your favorites.
B,
B, A, B,
A, B, and D. So that's a sign of an ectopic. All right, so the nurse asks you about, what should be reported to her doctor. What things would you list?
bleeding,
Yep, bleeding, blood pressure, that'll be good. Vomiting, because of too much vomiting. Too much vomiting, that can now cause a problem. So we don't want to do that. Reduce fetal movement, okay? So a sudden gush of fluid from the vagina, for sure. Belly pain. A fever, blurred vision, persistent vomiting, headache, edema, convulsions, oliguria, dysuria, and then that decreased fetal movement. So changes in the body caused by pregnancy include relaxation of the joints, center gravity is off, faintness, dizziness, or discomfort. These changes can lead to problems with coordination. So in teaching her about safety, what would you talk about?
She's not supposed to wear high heels. Wear proper shoes. You know.
Well, the high heels definitely change your center of gravity again.
Yeah.
You lose your balance. Yeah, that could be problematic. Keep floors clean, free of clutter. Use good body mechanics. So when lifting objects, use any safety features on tools and vehicles, so safety belts, helmets. Avoid activities requiring coordination, balance, and concentration, or that can cause a sudden jarring movement. So like don't get on the, what's that, the Texas roller coaster, what they call that ride at Six Flags? So I wouldn't get on that one. Rest in between. Reschedule activities to meet rest needs. All right, so she asks, is a vaginal exam done at every visit? What should you say? All right, I got a D. Oh, big text. Thank you for that, Martin, because I was like, I know there was something Texas. All right, so should we do exams every time they come in there? So if you had a kiddo, you would know, you might know the answer to that. D. When you get down to those final weeks, you may start to have, the cervix may start to dilate. So we want to know that. Just, make sure. All right, so you tell her that the ultrasound may be done at about 8 to 12 weeks to check fetal growth, and then you keep going. So in PIH, you just need to know what signs and symptoms. Sometimes people get it because of the pregnancy. Sometimes people already have high blood pressure before. So it's not really pregnancy induced at that time. It's just basically hypertension. So if they were normal before, between the 110 and the 119 range, and then got pregnant and now they're in the 140 range, that's different. Now that's pregnancy induced. And what's the cardiac arrest rhythm that they can go into due to that magnesium imbalance? Let me see if you remember.
Torsades.
Torsades, that is correct. Oh man. Oh, well, to remember, torsades was the accordion. That one. Okay, I think that's the end of that. All right, where do you want to go next?
I have a question. Are we going to do all the case study, or are we going to do something else, the other example under the perfusion?
That's up to you guys. Remember, I asked you, where did you want to start?
I think we can touch the other exemplar, because we haven't. That's just me. So that's what I think. I don't know if everybody else is.
But what have you, tell me what you've done on the other exemplars.
Um,
So I'm not against, I'll go wherever you want. But I want to know what I'm starting with.
Elimination, we have not touched that one.
But well, I told you we would do that on Tuesday.
Okay. And on the perfusion, the mitral valve collapse, we haven't done it. The coronary artery disease and the peripheral vascular disease, we haven't done that yet.
Okay, so I ask you again. Where would you like to start on either of those? So we could do cardiovascular, we could do the mitral valve prolapse. I am A-okay.
Yeah, I'm okay with starting with the mitral valve prolapse if everybody else is.
Okay, so tell me what you've learned thus far about mitral valve prolapse. So has anyone looked at mitral valve prolapse?
Is it when the mitral valve is faulty
Right, that is true.
and the blood flows back up into
So
the
we have
atrium?
regurgitation. That is true. Okay. All right, so I'll tell you what, because I mean, if you're waiting on me, remember, you guys have just as much responsibility to these exemplars. So if you're waiting on me to do the exemplars, then I would say that's a little bit out of order, because you should be studying that material just as well. But I am fine with it. However, you still need to, that's why I asked you, what can you tell me what you know about mitral valve prolapse? And then we'll move on from there. But let me finish organizing this real quickly, and then we will oops. Then we will proceed with mitral valve prolapse. And I'm not sure if this is already on your course board. So that's why I'm oops. There we go. I think that's the end of that. Oh, no, one more. So I'm getting ready to pull up a case study is what I'm getting ready to do. All right. So I will share my screen. And then we will proceed. Okay, so here's your case study. So the question is, what are your risk factors for this patient with PVD? I'm gonna start with that. And then that should dovetail into mitral valve prolapse.
The risk factor, he's a smoker. He have diabetes. It's okay. 26 years old. Left female computer bypass occurred 5 years ago. Smoking and diabetes.
Okay, type 2 diabetes. What's a FEMPOP? Help me out here.
Can you repeat your question, please?
What is a FEMPOP? Oh, femoral popliteal bypass. Thank you. I was like, a FEMPOP. Okay. So anything else? Or the PVDer? It's okay. All right. So let's one more. Let's see. Absent fetal pulses. Okay. So
Would his age be a factor?
Yep, age is definitely a factor. So previous bypass surgery, age, smoking. So what additional assessment information do you need?
We need his weight. If we can get his weight. His blood pressure right now. Maybe check his blood pressure.
Mm-hmm.
Ask him when was the last time he took all his medication. Ask him if he's compliant with the medication, how often he takes his medication.
Okay.
History and physical.
This is assessment. So we're going to look at skin color. We're going to look at skin temperature. We're going to look at, do they have edema? We're going to look at their condition of the skin, blood sugar levels, allergies, vital signs. This is on PVD. What diagnostic tests would you think they'll get? So, and this is kind of review. because we covered that when we did clotting. We covered the same thing when we did clotting for DVT. So you got to remember the difference when we're talking about peripheral vascular disease. That is both venous and then an arterial component. So if you remember, you have to go back and that your venous is more warm and have edema and swelling, where your arterial, your skin's pale, cool, cyanotic, absent pulses, etc. So we want to look at probably an ultrasound to be done, some lab values. So a Doppler, ultrasound, pressure measurements, angiography, MRI. Top 3 nursing priorities.
Circulation.
Safety, okay.
Breathing.
Gas exchange.
Mm-hmm.
Okay. So blood pressure, monitor perfusion in extremities, blood pressure, blood sugar management, pain management. Teaching. We're gonna teach them to get up and do a jig? No. If it's a DVT, then, you know, we're making sure that it doesn't travel and then become an embolism. So risk factors that we listed above, lifestyle changes, but they do need to exercise, stop smoking, manage their diabetes better, and then do foot care. All right, so here's our mitral valve prolapse patient. I'll make it a little bit bigger here. So what other information do you think you need to know?
Is she taking any other medication besides the Lantus that can maybe causing her to have palpitation? Ask her about her medication. How long she has been having those symptoms?
Okay. So vital signs, allergies, home meds, and other medical history. So what is a prolapse, a mitral valve prolapse? So this is where a portion of the mitral valve becomes contracted during, it's a portion of the mitral valve that prolapse into the atrium, the left atrium, during the ventricular contraction. Would you expect to hear any abnormal heart tones with this? And if so, what?
Would it be the same as a murmur?
It's a murmur, but they also have a click, a systolic click. So when you hear it, when they replace it, then you'll hear a click when they put in a new valve. So they can have murmurs, that is true. So the leaflets that are there, the chordae and the papillary muscles, somehow they become dysfunctional. They may be elongated, but they actually start to bow or bow out of one or both of the leaflets. So they end up with mitral valve regurg, which basically means instead of them closing straight, it creates an opening where blood flow can back up. So they're not prominent like they are, or flat like they used to be. So things like heart disease, like a congenital heart disease, is this genetic? Yeah, murmurs is different than a flutter. So is this condition genetic?
No.
Actually, in women, it is. It's possibly an X-linked inheritance. So it could be genetic because it's an autosomal dominant inheritance. It could, people that have Marfan syndrome, do you know what Marfan syndrome is? M-A-R-F-A-N. So M as in Mary, A as in Apple, R as in Robert, F as in Franklin, A as in Apple, N as in Nancy, Marfan syndrome.
Is that where they're like extremely tall?
Right, so they have the long limbs, long lengthy fingers. Usually this is like tall white males that smoke. They end up with this Marfan syndrome. But this is really a connective tissue disorder, and this particular disorder can be in several different areas, but also other connective tissue disorders like lupus can be a cause. So there's several causes. Rheumatic heart disease, coronary artery disease can also lead to a mitral valve prolapse. It is more common in women than men. So just kind of, you know, although guys have an issue more with the Marfan's component, but women tend to lead the charge here. And if they have it, it develops between 20 and 40 years of age. So usually they're tired, they have palpitations, they have shortness of breath, they can't really exercise, they have exercise intolerance, they may have chest pain, they could have orthostatic hypotension. What types of studies would you do to actually diagnose it? What kind of diagnostic studies would you need? What kind of imaging?
Echocardiogram.
They need an echo, E-C-H-O, an echocardiogram. That may let them know or give them some information about, you know, the leaflets and how thick they are. They can look at how they function during systole and diastole. So there's some options to figure out. They can do also put them on a Holter monitor, which is basically an ECG, to see if they have any abnormal abnormal rhythms. Sometimes for treatment wise, they may just monitor it. If the person smokes, they're going to tell them to quit. Stress management. And because we do have that bowing that happens, that can also lead to blood becoming stagnant. And then what will form when blood becomes stagnant?
Clot.
They can develop clots. That is true. So what kind of diet would we be talking about here? Should they be drinking? Should they intake alcohol?
No.
Nope. And should we give them caffeine?
No.
Or if they're drinking caffeine, we probably need to tell them to decrease it or to stop, but they need to stay hydrated. So patients, if they do have to, if it's, you know, pretty bad, if they have mitral regurgitation, then they will go to surgery and get a mitral valve repair. But we would anticipate, if we're going to prevent clots, that they're going to be on some type of anticoagulant afterwards, like aspirin, right? Or maybe Coumadin. We would monitor them for any antiarrhythmics, and if they have that, then we would treat them for that. Give them a beta blocker, so that way, if they have palpitations, this would actually stop that because it'll slow the heart rate. There's some other things that we could do, like nitrates to decrease how much afterload they have, which is how much blood that's being pushed out into central circulation. So, any questions about that? So monitor vital signs, their activity level, their coping strategies. Those are all the things that we're going to look at. And then they actually have some leveling of the particular murmurs that they can develop. So we'll talk about that here in a minute. All right. So what documents do you need to take into the patient's room when you go see them? Say that again. Assessment sheets, okay. Anything else? Need your computer on wheels. You need everything. You need admission paperwork, diet, all of that. Social history form, INOs, nurse's notes. You're going to be filling that data in. Bracelet, allergy. The equipment, stethoscope, thermometer, pen light, gown, non-skid booties, just the regular admission stuff. What diagnostic test do you think will be ordered? So an echocardiogram, 12 lead to see if they have any arrhythmias, ABGs, and that's because of the shortness of breath. We want to see if they're respiratory, alkalotic, acidotic, metabolic alkalosis, or acidosis. So they confirm it. What assessment findings would you expect to be there when they confirm? Regurgitation, okay. Fatigue, shortness of breath, lightheadedness, syncope, a mitral click. Remember I said that may be one that you hear, mitral regurg or mitral murmur. All right, do this here. All right, here's a second case. What concerns do you have about her vitals?
Her heart rate is high, 120. It's 120 and is irregular.
Okay.
Respiration is 24. That's high. And she's not over 150 pounds. And her blood pressure is fine.
All right.
The
So
pulse and her respiration.
she's tachycardic, her respirations, her BMI, her blood pressure is borderline. Is there anything about the doctor's orders that you should question? And if so, why is it an issue?
Where is the doctor order? Can you please put the case study back on the screen so we can look at the doctor order? We can really see it.
This is what I have here. Oops, case study number 2.
I read this one. G5 half ms.
Have her call for help, see if she might fall. Okay, bathroom privileges. Okay, so let's see. Depending on her glucose, the IV solution may need to be changed. The diet may be too many calories, and her bathroom privileges, she will not have much activity or exercise. All right, additional lab work. What will we do for additional labs? And why?
Maybe a A1C to see.
Okay. So a CMP or BMP, low perfusion pressure can decrease blood flow into the kidneys and then cause her to retain fluid. So we want to get a chemistry panel. CBC to see what her H&H is doing. White cell count and platelets, because platelets can become damaging or become damaged because of the valves not functioning. And remember, they can develop clots. All right. Next mitral valve case, part 3. I think it's the same person. This is the same person, but now we're just giving updates. Temp pulse, okay.
Her nails look blue. That means she's cyanotic.
Okay, pulse ox.
Her
All right. So,
her blood pressure is decreasing.
okay.
It's borderline, but it's decreasing. Her respiration, she's tachypneic, is 26. So she's cyanotic, tachypneic, and low blood pressure. Her blood sugar is high.
Yeah, we got that. Her chest hurts. Blood BP is not high, it's low, isn't it?
Yeah, her BP is low, but her blood sugar, her glucose level is 250. It has increased. Restless and stay. I don't feel good. She has a report her breath. She could listen her heart, but it's not just good.
So, all right, are you ready to call the doctor?
Yes.
This will be a part of this S-bar. All right, so no, you need more details about her chest pain. When did it start? What's the characteristics? How long did it last? What brought it on? What activity was she doing? When did she start to feel short of breath? Make sure she's sitting in a semi or high Fowler's position to make it easier. So we're not quite ready yet. We still need some more assessments. And it doesn't mean that you won't call him or her shortly, but remember that whole S-bar format. So I think we know what S-bar, if we don't know what S-bar is, this is what an S-bar is. So people say, hey, we're going to give the situation, but when they give the situation, they don't really give the real situation. And I know that sounds convoluted, but if you're talking about giving the situation, hey, this is Miss So-and-so that was admitted to your service for blase, blah, blah, blah. I'm calling today because she's having difficulty X, Y, and Z. So her history is yada, 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 yada. When I assessed her, this is what I found. She was complaining of chest pain. She said it started here, there, wherever, wherever. She had these signs and symptoms associated with it. Does that make sense?
Yeah.
So you have to give that full, complete process. I'm recommending that we do a, draw labs or get an ABG or get a particular study. So that's how you go through that process. So they're just like, hey, this is your patient in room 202 that was admitted yesterday. Okay, who's in 202? Do you see what I'm saying? There's a huge difference. Okay, so how would you organize your information? So vital signs, assessment findings, breath sounds, nail beds, murmurs, clicks, blood sugar, and then remind him about the IV fluids that he ordered. What concerns do you have about the new assessment data? The O2 sats are low, and these are things that you've already covered. This is why I'm just kind of not really zipping through, but they were either mentioned verbally or in the chat. Tachycardia, tachypnea, patients complaining of chest pain. What do you think has caused these changes? Now we're looking at heart failure from the mitral valve. Okay. So what is the priority that you should report to the doctor? The vital signs, the oxygen sats, the shortness of breath, and then the chest pain. What are you most concerned about? The chest pain, because that could lead to respiratory problems, and her O2 sats already low. So I'm not going to break you up into groups, but these are the different types of murmurs. So you would expect to hear murmurs, and if they have had a valve replacement, then you're going to hear clicks. So it'll be a click instead of lub dub, be clicked up, clicked up. Does that make sense?
Okay.
So it won't be your normal heart sound that you would hear on someone that doesn't have an issue. Where would you auscultate? So where would you auscultate, to listen to these breath sounds?
Fifth intercostal space.
The fifth intercostal space, mid-clavicular, left of the sternal border, where?
Fifth intercostal space, mid-clavicular.
Okay.
Right up under the nipple line.
Okay, so did everybody get that?
Yeah.
So the fifth intercostal space, mid-clavicular line, that's where you're gonna put your stethoscope to auscultate, okay? So does that answer you all's questions about the mitral valve prolapse? And there's different types of prolapses, but we're just speaking about mitral valve because of the perfusion issues. Does that make sense?
Yeah.
Okay. Will you need to know all 5? I don't believe so, but I can verify and let you know on Tuesday. And then we'll talk about the difference between angina stable and then angina unstable on Tuesday. Elimination shouldn't be that difficult to cover. Don't forget about your, I think it's the, thinking about your level 1 concept. Isn't it sensory?
Yeah.
Yeah. Someone say sleep.
It's sensory and sleep.
Okay, yeah.
Also, There is a part of elimination that is level 1.
There's a what of what?
There is a part of elimination that is level 1.
Yeah.
And yes, so it's elimination level 1, sensory perception and sleep.
Okay. But you know, we'll address it. But remember, you guys need to read that stuff and do the PowerPoint so that you have some background, you know, before the lecture. But yes, we will cover the elimination and because we moved out, I think it was Crohn's or something like that from this lecture, but we'll talk about neurogenic bladder. And I think it's a intestinal obstruction and things of that nature on Tuesday. And then we can Zoom again next week. Would it be better to Zoom on Thursday or Friday? I mean, Thursday or Saturday? Probably Thursday. Math is on this. Yep, math will be on this test as well. And I think you guys are going to go to 60 questions. I think. Not sure about drips. I can ask Mrs. Johns. But do you need some help with calculations? We're already at 60. Okay, then it may stay the same. So I think she did 50, 50, 60, 60, if I remember correctly. I sent that to you. I gave it to you already. Someone asked about a comprehensive, send you a guide for the comprehensive review for the final. I sent it to you for the HESI and said that you could use it on the comprehensive exam, this may help you. But I emailed that out probably about 5:40, 5:45 this afternoon.
Yeah.
So I did do that. That'll give you time to work on it over the break. So start early. So he goes, LOL. So was there a math question that you specifically had about the math? No? Anybody?
Really?
Are you guys like worn out and tired? All right, then, if nothing else, I will see you on Tuesday. Have a good weekend.
Okay, thank you very much.
You're welcome.